Good morning. So I am also in a private practice. My life is a lot more similar to Stephen than in industry. But I was listening to his presentation, and in a way, my life is very different. And some of the things he said, I noticed that maybe would not have applied to a woman, which is not something that I would have thought until I came here now. My presentation will tell you a little bit how to select a job and what is important in a job, and I think it applies to all jobs, not only private practice or academia, but it will also be sort of like a collection of what can go wrong so that you know what can go wrong and you can prepare for it, and hopefully it won't happen to you as I know it has happened to other fellows. And not even fellows, just young physicians looking for jobs. So we talked about what's important in jobs before, and I think there are three factors. They interplay with each other, and they're really what Stephen said before: money, time, and control. You can call it control, you can call it choice, you can call it options. It's a way to make your own choices and to select where you want to work, when you want to work, with whom, and what you want to do. Because I am in private practice, but I am also in a big multi-specialty group, my experience is a little bit different because I need to coordinate with my partners, but also with all the other specialists and also the primary care physicians in the group. And I've also worked in academia, although a smaller academic center in the city, and I'm able to compare the two environments. So let's start with money, because I suspect at the end of fellowship, money is probably what's most important right now. You have been used to the fact that time is fully available and your time is still not very expensive. So what matters the most at this time, I think, is money. So we'll start with that. And first of all, when you look for a job, and these are all things that I wish they had told me when I was looking for a job, but it seemed that there was almost like a black curtain discreetly pulled on money, especially. You go for 3 interviews and you never ask about the money. It seems that's bad form. Nobody ever mentions it, as if they didn't get a salary, if they didn't get, they didn't wake up every morning because of the money, or even worse, they didn't check our RVUs every month. So money, go online and look the benchmark income for whichever area you want to choose. And I will show you what the benchmark income is. And decide, if you know ahead of time that you want to do academia, see what the benchmark income for academia is. Or see what it is for private practice, or see what it is in that particular town, because it may also change within the same counting from one town to the next. Then there are differences between employed versus ownership. And then we'll also talk about salaried versus productivity. Employed versus ownership, I think the most important thing that I have to say that Stephen hasn't said yet is that there are benefits and drawbacks to both of them. When you own something, you're responsible for it and you need to run it, and that takes time. When you're employed, you show up and most of the system around you is already set up and you don't need to put any time into it. At a time in your life when time becomes very expensive, let's say $500 an hour, to be realistic, you have to think about it that doing paperwork, it's $500 an hour. So there are only 24 hours in a day. You can spend it with your family, you can spend it doing paperwork, you can spend it ordering desks and choosing carpet, or you can spend it doing colonoscopies. And those are choices that one has to make. I did some research, and it appeared that employed versus ownership situated physicians actually had sort of the same level of satisfaction. So it seems that they were mostly at peace with whatever decision they made. Salary versus on productivity. That is a little bit tricky, and it depends really on how fast you can work and how fast your partners will work. Because you want to be sort of on pair with your partners. You do not want to be the runt of the litter. And if you choose to work part-time, that by definition, when it comes to looking at your productivity, becomes the runt of the litter. Because at the end of the month, at the end of the 6 months, you have made a lot less RVUs than your partners. And RVUs have a 50%, 40%, it depends, overhead, which means that 50% of what you bring in goes to the practice to pay for the secretaries, for the nurses, for the telephons, for the office space, for the endo unit. We have an endo unit. So if you're bringing in less, it means that the group as a whole has less money to share for all the other expenses. And after a while, that may be locked down. Just something for everybody to consider. It's not really being mean, it's just the way it is. Partnership. And here the story is a little bit different than what Stephen said earlier, and I'll talk to you later. And then teaching, I had to experience teaching on my own back, I would say. And I would say teaching is not meant for private practice, and sometimes it's not even meant for academia if you are on productivity. So I will give you my experience later on. But what I want to highlight here is scoping sessions versus inpatient versus clinic. When you will get that first job, do discuss your schedule very clearly, because you may find out that your senior partners will have 6 sessions a week, and a session is a half a day. So if they work full-time, it's going to be 10 sessions. And if your partners have 6 or 8 sessions of endoscopy a week, and you have 6 or 8 sessions of inpatient or clinic a week, which makes absolutely no money, and you are on productivity, you will be making less than a PCP. Just something to be very careful and bring up at the time of the negotiation. You may not even know what a session is. I didn't know what a session was. I thought, a session, okay, I don't know. And then you need to find out how many patients per session. But definitely discuss ahead of time. Will I be covering the hospital? Will I be in clinic? Will I be scoping? So I thought compensation by geographical area was very interesting. As my son said last night, looking over this, whoa, the Great Lakes pay a lot of money. And yes, the Great Lakes do pay a lot of money. Apparently, actually, the highest paid state is right now Dakota, North Dakota. So if you want to go to Dakota, you can really make a lot of money. I think it was actually mentioned on CNN that people are trying to, well, there are a lot of jobs in Dakota right now, and one of the highlights is Walmart. I guess Walmart opens. So if you're a fan of Walmart, please do go to Dakota. Otherwise, the places where people want to be the most, I guess, are the Mid-Atlantic, the Northeast, and California. However, because the West, in particular California, has higher taxes, at the end compensation between the Northeast and California are pretty much equivalent. It's not those $4,000, $5,000 that make a difference because their taxes are higher. But if you really want money, you may have to move from Northeast, and definitely you may have to move away from New York State. So next, compensation by practice setting. And here I was kind of surprised because I always thought somehow that the small solo practice was the one that made the most money. And apparently not. It is really not the case. So the ones who make most money are the multi-specialty group practices. And then you can see that there is the single specialty group practice, so I guess a bunch of gastroenterologists, and that's going to be definitely higher if they own their own endoscopy center. And then there is a big healthcare organization, and you can see outpatient clinic. Hospital is probably increasing, although these are from 2014. So these are all records that Medscape obtained from sending out surveys, and they are just being done. I would have expected hospitals to be higher, but apparently that's not the case. And then I think that has already been mentioned that academia tends to be a little bit lower. It's the lowest, but you do get other things in exchange for it. Teaching. And here I'm going to tell you the story. So I was at this partner, say, in the Harvard system. And at a certain point, I was told that I had to teach. Not only I had to teach, I had to teach scoping to residents, which means that they were not fellows. They were surgical residents. But I was also on productivity. So my day where I would do, let's say, my 12, 13 cases became a 5-case day. And after 6 months of that, during which I pretty much donated to the institution at least $25,000, $30,000, having said that I could not sustain that kind of job, I left. So be careful, because if you want to teach, it's going to cost you, unless you want to stay in academia where the setting is appropriate and you can do it. So it's time-consuming, as I just showed everybody. It lowers productivity for you and the group, and in certain private practice groups, actually, it's looked down because, as I said before, it lowers productivity, and at the end of the day, people go to work to make money. It also affects patient satisfaction. Not all patients may be used to see fellows or see residents in the office. They really have a very close relationship with their doctor. I have a lot of my patients who text me. They have my cell phone. They text me. That's fine by me. They're very respectful of my time. But when they walk into the room and they see somebody else, they see that relationship with their doctor almost being violated, and they don't appreciate that. They may tell you the next time when the fellow or the resident was not there, I didn't tell you, but. Like, okay. Clinic, however, is more doable than endoscopy, mostly because RVUs for clinic are much lower, and also because the fellows and the residents can write your note. So in a way, they can make you a little bit more productive later on. And if you do choose a job and you really want to bring in teaching into it, just make sure that somehow you'll be reimbursed for it, because otherwise it's going to be costly. Partnership. So partnership is another one of those fun stories that I have. And unfortunately here, I never thought I would say this, but all the horror stories apply to women, not men. First of all, partnership is not available in every state. For example, in New Hampshire, there are no more self-employed physicians. They're all employed, 100%. So you need to be able to find a practice that offers it. You may really want to talk to the people who have been at the practice before and may have left after those 2 years or a year and 10 months. It may happen that if you were part-time, or you had said before that you were going to go part-time, maybe later on when you would have more children, that the rules change, that you would have to buy more into it, or that you would not be qualified anymore if you worked 4 days instead of 5. So I do know a couple of practices in this state, actually, who have had a number of young women joining them for the first 2 years just to leave because the rules at the end of the 2 years had changed. My recommendations here is call the person who was there and left and get their story, because it will be different than the story that you hear from the partners. But if you get all the stories together of all the women who were there, they were sort of the same stories. And it's true, women may want to work less. Actually, I also do not know any woman gastroenterologist in my group of acquaintances, granted, who is willing to work 5 days a week. None. Everybody's working 3.5, 3 or 4 days a week. So I understand that if the other people in the group are working 5 days, they feel that they're almost making a favor to this woman. But just be careful. And also there are more and more young women entering the workforce, especially in GI, so we will have more power to say, no, this is what I want. Ask and just beware. What else? Yes, and then finally, the other point, what is happening right now, there have been a lot of mergers and acquisitions, and so partnerships may not even be available while they were available to partners that were just joining 5 years ago, because a lot of smaller practices may be joining bigger practices with different tracks and different goals in general. So even though the partners may have offered you partnership at the time you join, the entire situation may have fluctuated so that it's a different landscape altogether. Just be aware. I think that's a general situation in medicine. It's not really easy to escape it. Be prepared for it. Time. As I said before, very important. It's either time, money, or control. So be aware of part-time versus full-time. It's different in every practice. In my practice, full-time is 4 days a week, not 5. Nobody works 5 days a week, so it's easy. Be very clear about what is considered part-time, and if you choose to be part-time, be clear and ask how it will affect your benefits, because you may have to pay more for your health care, for health insurance, more for dental care, more for all your benefits, and that will affect you. Time, office support is key. Find out who will send your letters, who will call your patients, how you're going to give your results. Because if you're calling all your patients for every colonoscopy result and all of them will want to make small chat for 5 minutes, it's going to be very time consuming. So you definitely need a support person, and you want to know how many support people are available for how many gastroenterologists. And then direct access for procedure. I think now it's pretty much standards everywhere, but it's another thing to inquire, because that's a nice way to have all your procedures laid out for you without having to see the patients before, for which you're not paid, by the way. So there should be a system with a nice base of primary care physicians who are referring doctors to you. And I mentioned before the difference between time and money, and also the difference between what women find and what men find in the workforce in gastroenterology. So men still do make more money than women. However, women are more satisfied. So the one thing that I can take out of this is that women are probably working less, and they're happy to be making the kind of money they are, despite the fact that they are working less and they have a flexible schedule. So it's not a bad career for women at all. You just need to know what you're getting into, and you need to be able to say what you want and what you don't want. Holidays, it varies greatly between practices. I'm just going to give you ranges here. It's between 5 to 10 days in general. Vacation ranges amazingly between 4 to 6 weeks, but there are a lot of physicians who don't even take the 4 weeks we're giving to them. So in my practice, we all take more than 6 weeks. We're very lifestyle oriented, but a lot of people are not taking it. CME, it's pretty standard, 1 week. Mostly it's required for licensing that you do your CME, so 1 week is standard. And then sick and maternity leave. It goes for none, very interesting, to 3 months. One of my interviews, I sat down and a woman came in and said, well, I hope you are not going to have another child. And I was just horrified, because it's illegal to ask that. But the reason she was asking that, it was not to make me feel bad, is because she had just had a child and she got 0 maternity leave. So she was passing along her experience. And because she was in productivity, she pretty much got 0 salary for 3 months, which if you're making $400,000 a year, 3 months is $100,000 a year less. Just to put everything in perspective. And at that time, if there are private schools to pay and if there are mortgages to pay, it makes a difference. Vacation, I found just interesting. Gastroenterologists, as I said, take about average vacation among all the other doctors, but less than 20% take more than 4 weeks a year. And time. Again, ask about the vacation philosophy of your group. You do not want to be the only one who takes more than everybody else. Also, do not underestimate commuting time, especially if your practice has an endoscopy center in one area, the office in another area, and then they're covering a couple of hospitals. 10 miles means 15 minutes. So you end up spending about an hour of commuting time every day. And control. So schedule choices. I think control is what makes you happier day in, day out in our practice. It's being autonomous, it's being able to make your choices. Of course, your choices affect other people. So call. There's short-term painful, which is what I have now. But I am on call Q10, which means that I've been on call in fall, then once in April. I'll be on call in August. It's so far away that I don't remember. Before my call was long and boring. Very benign call. I wouldn't have to go in, but I also couldn't leave the city at all. I always had to be somewhere within 10 miles to be available. You never knew. I'm an avid skier. We couldn't go anywhere. The kids grew up. I said, I've had it. I want to be able to go. Now I do this 5 weekends a year. It's totally doable. It's not a benign call. I was on call last night. I went in. My call usually means maybe I have a black cloud. But it's 10 consults usually, a couple of procedures every day. I covered 3 hospitals. So my colleague did a long weekend, and he did 27 consults during a long weekend. Not a benign call, but it's rare. And in between, we have completely free weekends. And that is what my group chose by uniting different practices and having a worse call, but not more sparse, I would say. Flexibility, that is something that you need to discuss with your partners. You really need to find out what is their philosophy. What do they want in life? Because if they want the easy call Q4, then you're going to be in conflict with them. So you need to find people who sort of have the same priorities in life. And priorities may change because kids grow up, things happen, but they need to have the same philosophy, that maybe time comes before money, or vice versa. Just find a good match. And then there's also, if you pick a place where you're salaried, being able to give input about policies, give input about what you want. I was in a practice where, because I was scoping in the operating room, I had to follow the same guidelines as the surgeons. So one day, I don't know, the cooling system wasn't working, and they told me I couldn't scope because it didn't meet criteria. I said, but this is not a clean procedure. So as I'm there in my gown with crap all over, they tell me, no, you can't scope because it has to be sterile. How is this sterile? But the nurse manager is in charge, and I didn't have the power to say, no, this is not acceptable. I did say it, but it did not meet the guidelines. And finally, I would say patient population is very important. I spend 6-8 hours with my patients every day. It's not my colleagues, it's not my nurses, it's my patients. I have a relationship with them. So it's nice for me to feel that I'm taking care of people who are sort of like my family, my friends. And this is what doctors dislike most about employment. This is not being in private practice, it's just when you're employed. So it's the limited ability to make decisions, limited ability to increase your income. I'm not sure that that's just due to being employed. It's a really tough time out there right now. But definitely the too many rules, such as the one I just exemplified right now, being in the operating room and being told that it's not sterile even though it's a colonoscopy. And then less control over work, schedule, being told what to do. These are all things that at a certain point in life we put a price on, and you decide what to give up for. So I'll be brief. I'll tell you exactly what to look for. Again, make sure you research what your salary should be, because they will know that you're new at this, and they may lowball you. Ask about your colleagues' salaries. And if you teach, decide not to be on productivity. If you're on productivity, beware of teaching. It's going to cost you. Also, make sure you're not the only one who will be teaching in the practice. Make sure if you're going for partnership that you talk to the people who were there before and have left, at least 2 of them. Then clarify your schedule. Is it going to be clinic, scoping, hospital, how many sessions of each per week? Make sure you have some control over your schedule and over vacation. I think a very good way to do that is to negotiate your first vacation when you negotiate the job, so that they know and you get a sense of how they would take that request. If you do it later, you have lost all your power to negotiate. And finally, this is very important for you guys when you go out there looking for your first job. When you get that offer, especially if you have 2, that is your time to negotiate. That time the ball is in your court. That's when you have the power to say, I will take this, I will not take that, and put everything in the contract. Have the contract reviewed, but really write it yourself in nice, plain, clear language. Put it in the contract. And anything you put in the contract must be something that you can abide for. So do not write, because this may be in the contract, that you will complete all your notes within 24 hours just because you're excited about the job. Because realistically speaking, it will probably not always happen. And then that would be a cause to not let you go on to partnership. Any little thing can be a cause. And I think that's it. Thank you.
Excellent, thank you. I want to thank the first four speakers, Chin, Steve, Chris, and Elisa. I want to invite them up for the panel. We started a little bit late, so we'll do the panel now, and then I'm going to shorten up the break just enough time to run to the bathroom, get a coffee or a water, and then get going. John Allen, who's going to speak